Pharmacodynamics deals with how does a drug act, or in other words, the mechanism of action. Also, what are the effects, the desirable or therapeutic effects, or side effects, adverse effects, unwanted effects. In most cases, more than 90% of drugs have receptors. And drugs mainly act as agonists or antagonists on receptors. Here we have some examples for non-receptor mediated mechanisms. I said that more than 90% of cases we have receptors, but in some cases we have no receptor. For example, when we use antacids to neutralize the acid, it's only a chemical reaction. Acid in the stomach is neutralized by a base or alkaline substance. So there is no receptor. Another example is protamine. Protamine is a protein that antagonizes heparin. It can make a complex with heparin and neutralize the heparin. So there is no receptor. Sometimes we have physical means for the drug. Mannitol is an osmotic diuretic. Osmotic diuretic. It increases the volume of urine. But the mechanism is osmosis, and there is no receptor. Another example, we have liquid paraffin. And liquid paraffin can lubricate the feces. So it's used for constipation. And it's a lubricant. There is no receptor. Sometimes we have chelation. For example, we have penicillamine, a drug that can chelate copper ions. You know that Wilson disease is accompanied with copper overload. If the amount of copper in the body is greater than normal, we have Wilson disease. And penicillamine can chelate copper ions. So there is no receptor, and this drug can act on copper ions. This drug is used in cases of iron overload. In thalassemic patients, we have several blood transfusions. And since we have no elimination for iron, we have iron overload. In such cases, we use this drug to chelate iron and prevent iron toxicity. For receptors, you know that receptors are protein in structure. They are specific. It means that any substance or any receptor can only bind a few or only one compound. Receptors have been created for endogenous compounds. You know that we have several neurotransmitters in the body. Dopamine, norepinephrine, epinephrine, acetylcholine, histamine, and many others. So if we have these compounds in the body, we have receptors for these compounds. Receptors have been created for endogenous compounds. If we have insulin, then we have receptors for insulin. If we have growth hormone, if we have ACTH, FSH, LH, they have their own receptors. Receptors may be found in different sites, in cytoplasm, in nucleus, on organelles of the cell, and they have binding sites. You see acetylcholine as a molecule, endogenous molecule. Acetylcholine is found in the body. In our body we have acetylcholine. And here we have a drug, carbachol. It's not found in the body. It's a drug. Here, for acetylcholine we have receptors, muscarinic and nicotinic receptors. When we use this drug, you see that this drug has similarity with acetylcholine. You can compare these structures. We have some differences. Here you see NH2, and here we have methyl group. And we also have a methyl group here, which is not seen in carbachol. When carbachol enters the body, it finds acetylcholine receptors and binds with acetylcholine receptors. Is carbachol the same as acetylcholine? No. There are some differences again. You know that half-life of acetylcholine is very short due to action of acetylcholine esterase. We have an enzyme that degrades the acetylcholine. This one has a long half-life and is resistant to the action of the enzyme. So you see that only a small changes has produced some differences. Also, for acetylcholine we said that we have both nicotinic and muscarinic receptors. Carbachol has tendency for muscarinic receptors and it has low affinity for nicotinic receptors. Carbachol is an agonist for muscarinic receptors, and acetylcholine is agonist for both nicotinic and muscarinic. Here, you see that if we have drug concentration and its log scale, drug concentration, and here we have the effect. As you see, when we increase the concentration, little by little the effect is increased. And then we reach a plateau. After that, whatever we increase the concentration, we have no more effect. This is the plateau here. You see that from this part, as you increase the concentration, you have no more effect. Here you see that agonist, as you see, binds to a receptor and causes the biological effect, while antagonist binds to the receptors and blocks or reverses the effect of agonist. They have no effect on their own. So, antagonists have no effect by their own. They can prevent the action of agonists. Throughout the day and night, we have release of acetylcholine, even when we are in sleep time. We have release of acetylcholine. And if we use an antagonist, it can prevent the action of acetylcholine. Here, drug and receptor results in effect. Sometimes we have maximum possible effect or maximum effect. This is a complete or full agonist. Sometimes the effect is less than maximum. So we say that it's partial agonist. So we have full agonist and partial agonist. And for antagonists we have block of action. Here you see the full agonist. You see increasing the concentration, and we have the maximum possible effect, 100% effect. And here you can compare full agonist and partial agonist. For partial agonist, the maximum effect that is produced is less than full agonist. Here we have the maximum effect, about 60%. And here we have 100%. So we have full agonist and partial agonist. What happens if we use partial agonist and full agonist simultaneously at the same time? What happens? If we use both full agonist and partial agonist, what happens? Some receptors will be occupied by partial agonists. So when we use both of them, the effect will not be as a full agonist alone. In other words, partial agonist in the presence of a full agonist can act as an antagonist, since it occupies some receptors and it has not complete effect. You know that we have competitive antagonists and non-competitive. For competitive antagonists, the binding site is the same with agonist. But in non-competitive antagonists, we have different binding sites. In competitive antagonists, the action can be overcome by greater concentration of agonists, since there is a competition for binding. And if we increase the concentration of agonists, we can overcome the action of antagonists. But for non-competitive, it cannot be overcome by greater concentration. Here, you see agonist alone, this part, and here we have agonist and competitive antagonist. You see that in the presence of competitive antagonists, we can have the same action, but with a higher concentration. In other words, we can say that if we increase the concentration of agonists, then we can overcome the antagonist. Okay. Here we have a rightward shift. A rightward shift. Agonist alone and agonist plus competitive antagonist. Here, again we have agonist alone and non-competitive antagonist. You see that in the presence of non-competitive antagonist, we cannot produce the maximal effect of agonist alone. So in competitive, since there is one binding site for both antagonist and agonist, the binding site for both of them is the same. But in non-competitive, we have two different sites. In competitive antagonists, they compete with each other for binding. Agonist and antagonist. And the concentration of agonist is increased, then we can overcome. But in non-competitive, we have two different sites. We say that and we have agonist. Okay? For competitive antagonists, the same site is used. But what happens in non-competitive? Here, you see that non-competitive antagonist has another site. And then, when it binds, we have a change into dimensional structure of this site. When non-competitive antagonist binds with its site, we have a changes in the structure of the binding site for agonist. So agonist cannot bind with the receptor. Here we say how there is difference. Okay, we have two terms, efficacy and potency. Efficacy is maximal response that is produced by a drug. Efficacy is the maximal response that is produced by a drug. Potency is a measure of dose required to produce a response. So potency is a measure of dose. Suppose that we have two drugs as a sleep aid, hypnotic drugs. One of them can produce a sleep or induce a sleep by 2 milligrams. And the other is 20 milligrams. Which one is more potent? This one.
Potent 20 milligrams.
This one is more potent as the drug is used with a lower dose, then potency is higher. Morphine, when used as an analgesic drug, 10 milligrams is enough for an adult. We have another drug named fentanyl. And 0.1 milligram of fentanyl equals 10 milligram of morphine. Which is more potent? Fentanyl. So, for drugs in the same category, analgesics, antihypertensives, and those which belong to a class, whatever the dose is less, the potency is high.
Sir, efficacy, what about efficacy?
Let's see efficacy. You can see. Here we say that the maximum response that is produced by a drug is called efficacy. You see here, A, C, and D have the same efficacy. The maximum response that produced is the same. B has less efficacy than the other three. Okay? And here you see that potency of B is more or greater than A, C, and D. Is it okay? So potency is related to dose, but efficacy is depending on the maximum effect.
Sir, B does not produce the same effect like A.
Here you see the maximum response here, and A and C and D have a higher response. The maximum response that is produced by a drug is called efficacy. And potency relates to dose. Whatever the dose is less, the potency is higher. Is it okay?
So is it possible?
You know, we have a class of drugs called NSAIDs. NSAIDs, like ibuprofen, aspirin, okay? Aspirin, ibuprofen. These drugs belong to NSAIDs. We have also opioids, like morphine. Opioids like morphine. Both NSAIDs and opioids are analgesics, painkillers. Okay? Pain. In such cases, opioids are used, since we have a severe pain. But for mild and moderate pains, we use NSAIDs. This is because efficacy of opioids is higher than NSAIDs. So, for potency, if you want to compare the potency of two drugs, you see the dose. And if a lesser dose is used for the drug, then we have more potency. You should use about 40 milligram ibuprofen each 4 to 6 hours. But morphine is used 10 milligram each 4 to 6 hours. You see here 10 milligram, and here we have 400 milligram. Potency of morphine is higher. Efficacy is also higher. We have a term ED50. ED50, or effective dose 50, is the dose that produces 50% of maximum possible effect. ED50 is the dose that produces 50% of the maximum possible effect. Also, we have LD50. LD50. LD50 is lethal dose that kills. LD50 in animals is defined as the dose that can kill 50% of animals. So, for ED50 is the dose that produces 50% of effect. For LD50, the dose that kills 50% of animals. And the ratio of LD50. Here, you see that ligands can bind with receptors. and can induce a cascade of biological effects or biochemical reactions in the cells. So when agonists bind with receptors, then we have a cascade of biochemical events in the cells, which finally results in the response. Finally results in response. Sometimes we have non-specific binding. Here we have a specific binding when the drug or the ligand binds with receptor. It's a specific binding. But sometimes we have non-specific binding. There is no receptor here, but binding has occurred. Is more. Here you see that. For example, suppose that a drug kills with 40 milligram and it affects with 4 milligram. The ratio will be 10. Okay? And no, consider that the drug is effective with, is lethal with 40 milligram and is effective with 20 milligram. The ratio will be 2. Which drug is safer?
First. Second.
The first one, here. The ratio determines that we have a safety margin. So this drug is much better.
10 milligram.
If a chemist has synthesized many drugs for cancer, for hypertension, for diabetes, we have, for example, 200 molecules, and we want to test them. One of the most important tests is here. We check the LD50, we check the ED50. And if LD50 and ED50 are close to each other, it's on drugs.
Sir, LD50 and AD50 close to each other, what does it mean?
If LD50 and ED50 are closer to each other, therapeutic index, as I said. We can determine LD50 in animals, in mice. We can determine ED50 and we can measure therapeutic index or the ratio of these two. In human, we cannot test the drug to kill the human. So these types of studies are carried out on animals. In human, sometimes we have estimation. For example, from toxicity centers. We have some estimation that the therapeutic effect is with, for example, 100 milligram, and we have toxicity with 200. We have estimation in human, but in animals we can determine both LD50 and ED50. Okay. Here again we have dose. You see the different dose of drug, increasing the dose. You can see the ED50. Here we have individuals responding. Okay? And we have ED50 here. Here we have little effect. killing dose. And again, we have LD50. And the ratio of these two is therapeutic index. We talked about agonists. We said that agonists can produce biological effect. We have two types of antagonists, competitive and non-competitive. We talked about efficacy, or the maximum response that is produced by a drug, potency, measure of dose that produces a special effect, and we spoke about ED50, LD50, and the ratio of LD50 to ED50, which is called therapeutic index, and is used as an index of safety. When agonist binds with a receptor, then we have some reactions in the cell. And in this slide, you can see that we have different forms of signaling. Some receptors, you see here, some receptors are ligand-gated ion channels. Ligand-gated ion channels. It means that these channels are closed. When agonist binds with the channel, then we have opening of the channel. Nicotinic receptors for acetylcholine are ion channels for sodium. So, they are closed in normal condition when there is no acetylcholine. When acetylcholine is released, it binds with a nicotinic receptor. It changes the conformation of the receptor or the channel. Then we have opening of the channel. And since the extracellular concentration of sodium is higher than intracellular, then after opening the channel, sodium ions enter very fast into the cell. We say depolarization occurs. Acetylcholine has a very short half-life. And I told you that an enzyme called acetylcholine esterase can decompose acetylcholine. So, acetylcholine can enter the channel, can open the channel, and then very fast we have removal of acetylcholine. So the channel will close again. You see that in depolarization occurs in milliseconds. And it's due to the action of acetylcholine and removal of the action. For some other receptors, we have also ion-gated channel. Do you know GABA? Gamma amino butyric acid. GABA has receptors, and receptors of GABA are chloride channel. So, when GABA binds with receptors, then we have opening of chloride channel. What will happen? Chloride is negative charge. Chloride is negative charge. So, when negative charge enters the cell, we have hyperpolarization. So we say that GABA is an inhibitory neurotransmitter. Okay? GABA binding to receptors, opening of chloride channels, entry of chloride with negative charge into cells, and then hyperpolarization. We have also glutamate. Do you know glutamate? Glutamate is an amino acid, glutamic acid. It's also a neurotransmitter in CNS. Glutamate is a neurotransmitter in CNS. And for glutamate, we have calcium ion channel. So here we have 3 examples. Nicotinic receptors, sodium channel. GABA receptors,
Chloride channels.
chloride channel. And glutamate receptors, calcium channel. Receptors are enzyme linked. Here you see. In this case, we have extracellular domain and intracellular domain. And intracellular domain has enzymatic activity. When, and here you have a binding site for agonist. When agonist binds with extracellular domain, then we have changes in intracellular domain. And we have the activity of the enzyme. Enzyme like tyrosine kinase, serine kinase. You know that kinase phosphorylates the substrates. So, in some cases, we have enzyme link activity. Receptor has extracellular and intracellular domain. And extracellular domain has the binding site for agonist. Intracellular has the enzymatic activity. After binding of agonist, we have the enzymatic activity. Phosphorylation of substrates. GPCR. G protein coupled receptors. GPCR. In GPCR, we have receptors that 7 times passes the membrane. And many receptors are found in this part. Also, some receptors can activate genes. Sometimes we have cytoplasmic or nucleic receptors for hormones such as cortisol, aldosterone, sex hormones like estrogen, progesterone, testosterone, and the active form of vitamin D, calcitriol, 1 and 25 hydroxy cholecalciferol. These have gene activation. When we have gene activation, we have expression of some genes, we have production of mRNA, specific mRNAs, messenger RNAs, and we have ultimately specific proteins. Let's have an example with aldosterone. What's the action of aldosterone in the body?
Increase that
Absorption of sodium and excretion of potassium. Okay? Aldosterone is produced by adrenal gland. The receptors of aldosterone are in tubules, kidney tubules. Okay?
Yes.
So, aldosterone is produced by adrenal gland. Its receptors are in collecting duct of tubules. Okay? When aldosterone reaches the cells, it enters the cell. It has cytoplasmic receptor. Then it makes complex with receptor. The complex goes to nucleus, binds with DNA, binds with DNA. We have gene expression, activation of genes, production of mRNA, a specific mRNA. Then we have translation and production of protein. The protein will be sodium, potassium, ATPase. So, if you see that aldosterone is absorbing sodium and excreting potassium, it's due to increasing the amount of sodium, potassium, ATPase. For calcitriol, what are the actions of calcitriol? What are the actions of calcitriol?
Increase in melanin treatment.
Increase absorption of calcium in the
Yes, increasing absorption of calcium in intestine. Also, increasing the absorption of calcium in kidneys. Okay? What happens with calcitriol? When calcitriol is used, calcitriol again has the same mechanism. It activates gene. But here we have a special mRNA, a special protein. And that protein is calcium transporter. So if you see that calcitriol is increasing the absorption of calcium, it's due to increased amount of calcium transporter. And also we have the same pattern for estrogen, progestin, testosterone. All of them are gene active. In summary, some receptors are ion-gated channels. Ligand-gated ion channels. Ligand-gated ion channels. We have examples. Nicotinic receptors, glutamate receptors, and also GABA. Some are enzyme-linked, some are GPCR, and some are gene activators. Next session will complete the